Thank you everyone for joining us today. This is Cassie Clark from the Washington Department of Health, and I am pinch hitting for Pat Justice. Today's topic is designing workflows for palliative care telemedicine in patient homes. And this is part of our work with the Washington Rural Palliative Care Initiative. I think this is number 7 or 8 in our series. And all of those can be found on the waportal.org site if you want recordings for those as well. Let's see if I can advance the slides. I did it. So this is just an overview of our goals. Our main goal is to really support and bolster the rural health systems that are in place to be able to serve patients within their communities once they receive serious or are diagnosed with a serious illness, and really working to move that upstream so that patients at time of diagnosis are able to receive these supportive services for their care and connect into experts, primarily using a telehealth platform, and working to develop funding streams to keep this work sustainable in these communities. We are blessed to have a number of supportive partners that have guided this work and continue to do so. And the community teams on the bottom are listed out of those who have been involved with our current cohort 1, and we are about to launch cohort 2, which is exciting. It just seems to be a delay in advancing the slides. I hope I didn't go too... Okay. There we go. Did I skip over one? Sorry.
A daily reminder.
Okay, so as I get back to our next slide, so this work really begins with community engagement and working on an asset and gap analysis within each community. In the first cohort, we had 7 communities. Not sure why I'm having trouble advancing, Tammy. I apologize. There we go. And after doing work within the community through the community engagement work, we move into the clinical skills and culture change to help teams learn more about how to deliver palliative care, and then work with this telehealth case consultation, which we have a monthly case consultation with a team of experts, a multidisciplinary team. We're working with 3 sites to try to implement clinical telemedicine in the home. And as I mentioned earlier, working on fiscal sustainability, and then hoping, as they are developing now, rural centers of excellence for this work. Today's session will be led by the fabulous Tammy Arndt, who's the director of Northwest Telehealth. And we have leaned heavy on Tammy over the last couple of years, especially recently with this, with all the new telehealth changes out there. So we appreciate your support, Tammy, in walking us through how to design workflows. I'm gonna go ahead and turn it over to you. Thank you.
Thanks so much, Cassie, and thanks everyone for joining us today. Give me just a quick moment and I will also bring up some other slides. So I thought the format today, because we didn't really have a formal panel, was I would start by sharing a few slides about workflow and our thoughts about how it works best for direct patient care. Then maybe ask some of our cohort panelists for some insight and perspective from their experience with direct-to-patient care in this virtual environment that we're in. We encourage all of our participants to either ask questions along in the chat, or if we don't end up with too many, maybe we'll have some direct questions and answers. So, but before I do that, we decided maybe we could poll people to see where they were at with direct-to-patient care, just to kind of get an idea of where people are starting from. So I'm going to launch the poll. You should be able to see it. It's a quick 3 or 4 questions. Feel free to go ahead and respond to that while I bring up these slides, and then we can get started. Hold on a second. And ready, get set. There. Can everyone see the slides? Thumbs up if you can.
Yep, we got them.
Perfect. Thank you, Michael. So again, today's topic is designing workflows for palliative care telemedicine into the patient's home. So with the unexpected onset of COVID, right, healthcare providers were faced with additional challenges of how to see patients outside of the traditional clinic setting. Shelter-in-place orders took effect, right? Healthcare organizations had to pivot and plan for safe delivery of care where the patient was located. Granted, not all care at the home is appropriate and is often used for follow-up visits to maintain a continuity of care, but with the assistance of technology, we aspire to provide the right care at the right time in the right place. And on the onset of COVID, that was the home. So when I think of workflow development for virtual care, there's kind of three buckets that you have to address, right? One is assessment. You need to identify the scope of service that you're going to provide and what the delivery requirements are. The second would be preparation, right? So to address all the questions related to the scope of service and delivery. And then the experience, how best to facilitate and manage the experience, not only for the patient, but for the provider, so there's a quality of care and the experience is positive. So I love to say failure to prepare is preparing to fail, right? So the things that you need to address, and this is kind of the overview of just kind of a high level, what you need to do is the patient type, right? So is this patient a good candidate for virtual care? So part of answering that question is what are the consult requirements, right? Can the requirements be completed via video? So if you're billing for Medicare, right, is the service and the provider type approved for billing? Now, part of our conversation is going to be in the land of COVID, lots of things were relaxed and we were able to do much more than we've ever had to in the past, more opportunity to deliver services. But in the future, that's still a question mark, right? So oftentimes if you're billing, are vitals required? And if that's the case, can you do that in the patient's home? Well, unless you have staff or somebody's in the patient home to help facilitate that requirement, then maybe remote patient monitoring or some kind of tool that the patient can use to satisfy it would be needed. I think of documentation, and again, for a telemedicine encounter, has the patient consented to participate? Is that consent part of the medical record? Is the virtual encounter versus in-person encounter noted in the medical record? So again, there's documentation requirements that go with our workflow and how we satisfy implementing the services. For billing, what are the requirements for billing a telemedicine encounter? Are the CPT codes have modifiers that denote it's via virtual, place of service codes for providers, right? And then there's the technical capability. Does the provider have the capacity and the location and the technology to deliver the care? And does the patient have the same capability to receive the care? And the metrics are what kind of benchmark measures will you monitor for success? So all of these things need to be looked at and addressed kind of prior to even implementing the services to make sure that we're prepared. So I can't have this conversation without HIPAA. So again, we're going to remember that HIPAA in the COVID era was very laxed, and you were able to use whatever technology you basically had, and payment was the same regardless. So again, keeping our eye on the ball of access and patient care was primary over everything else. But in the world down the road, post-COVID, there are things that we need to look at. And I think that when people think of HIPAA security, they think, well, it's a HIPAA secure software, so I'm good to go. But HIPAA security really means that you have a business associates agreement with the vendor. So that is a relationship that's established, right? It's a written relationship, and it's basically a duty to report any breaches. So without that, do you have HIPAA secure software? Is yes, but do you have the BAA to really ensure that relationship exists? The second thing is that all collaborative software Zoom, MS Teams, WebEx, whatever your software, they all have features that can be turned on and off based on use case. So we use software for educational programming, administrative meetings, and clinical care. The background features that are set on that software are turned on and off based on the use case. So when configuring a license for healthcare delivery, you want to make sure that there are certain features that are turned off and locked. It's administrative control on the back end. That's usually your IT people who do it. So for example, cloud recording needs to be turned off. That's a given. It's not an option to turn it on. That's done at an administrative level. And then recently, data center transmission grew exponentially with Zoom just based on, for example, all of their licensing and volume. So as an administrative on the back end, you want to make sure that all of the data resources were within the United States. So your IT people are really meant to be on top of the HIPAA and security and privacy rules and regulations so that they make sure that the software that they're providing you is set up accordingly. The other things are kind of administrative for the user. So I like to think of a virtual link as a virtual exam room, right? It's a space where the provider can meet with the patient. So when I think of that, the provider would never leave a door open in a clinic exam room when they're seeing a patient. They always close it, right? So what features do we have in our software so we can replicate that in a virtual environment? Well, because of all of the volume of things, for example, with Zoom, they implemented the waiting room feature. And it used to be that that was a feature you could turn on and off, but in today's world, it's a feature that's a requirement. And recently, in fact, I think today the new feature was passwords associated with your license. So, or whatever link that you happen to be putting out. The other thing we need to think of is the protocols for establishing a telehealth service, right? So consent, again, that could be separate consent for a virtual encounter, or it could be something that's added to your consent to treat in the future, because whether it's in person or virtual, right, you have flexibility because your organization is offering that. Scheduling, right? So there's options. Do I schedule a unique link for every encounter for that patient? Do I schedule a recurring link, like a virtual exam room that anyone can have access to? Is it my personal waiting room? Or am I using a tool in association with my patient portal that has like WebRTC where you click in and then just a video image shows, and it's not about clicking on a link. So we have all sorts of options for how we can facilitate the experience based on the software and what the tools are. So for direct-to-patient care, I think these are the very basic requirements, right? So internet access. I say this because not everybody has it, right? Wired is the best. Like recently at home, I got some fiber and I'm connected to my router, whatever it is. It's just so I have connected capabilities beyond Wi-Fi. That's the best case scenario, right? But you just need to have an internet connection. Software in today's world tends to flex bandwidth based on a patient's location. So that's good, the fact that you have some flexibility. And you can also know that if, for example, the video is poor, you can shut off video and audio is enhanced. So oftentimes the collaborative tools are video first, but there are ways to manage that if bandwidth is poor. So you definitely need a device capable of interactive technology or for interactive technology. So you need a camera, you need a microphone, you need a display to see somebody, and you need speakers or headphones. Those are the requirements. So historically, for telehealth and telemedicine, the requirement by CMS and all payers was a synchronous two-way audio video connection. In the world of COVID, because not everybody was at the same resource equity, they said, okay, we'll pay for a telephone encounter the same as a video encounter. You can use whatever software you have. We just need to give you access. So keep in mind that although that's been our present COVID experience, then in the future, it will probably go back to something that is more structured and standardized. So we cannot have a successful workflow unless we really prepare for this, right? And we like in the land of technology to say that this is where the rubber meets the road, right? So when we're thinking of this, we have to ask ourselves, how will the patient access the link? So this link is to an encounter with a healthcare provider. It's considered that we need security. It's not just sent over the internet to somebody's email address. Email is considered an unsecure form of communication, which is why there have been the development of things like patient portals, where somebody can go in, register, and put their name and password. There's secure email, the same thing. I send you a secure message, you still have to register by entering your username and password. But then there's also verbal instructions. So for example, I could say to you, if you go to this website and you click join a meeting, I can give you a number and I'll meet you there. So there's all sorts of flexibility depending on exactly how you want to set it up, right? Verbal instructions is kind of the last resort, but it's the easiest if somebody cannot figure out how to enter a portal or someplace else. So then you say, how will your provider access the link, right? So will you have the link associated with an EMR? So for example, if you can integrate Zoom software into Epic, right? So it ties into the billing, it ties into everything that all the requirements for the consult, and it sends a message in MyChart, which is their patient portal, and it says, here's your appointment, here's the time, here's the requirements for checking in, click on this, you'll enter a waiting room, and your provider will join you. So again, it's a more integrated place to place a link. But then again, for the provider, it could be a desktop icon. Maybe you're not using the EMR, right? And you've created his or her virtual exam room. It's shared as a desktop icon. Every time they click it, they immediately go in. In today's world, often now with Zoom is you need to go ahead and sign in so that you have the host controls to do that. So maybe the workflow is sign into Zoom from there, enter your meeting room. Then there's a landing page. A landing page is something that, again, it can be created in association with a website, with a URL, just any place that says, here's where you can go to click join and enter a meeting. So you have to decide who's going to schedule these appointments. And when I say that, I say it in two ways. Who's scheduling a virtual patient and who's scheduling the software associated with it, right? So let's just review. It's workflow. We already have a clinic. Why would we reinvent the wheel, right? So the front desk who does the scheduling for an in-person encounter should also be able to do for a virtual encounter. How will that look in our schedule? How will we denote it, right? So that's part of the workflow and those responsibilities. In terms of the software link, again, is it something that's integrated in the EMR? Is it a WebRTC and it's going to pop up whenever somebody initiates clicking on an icon? Is it going to be something where the patient goes to a message and opens up the message? Is it recurring? Is it unique? I advocate 100% for a recurring virtual meeting room. I don't think scheduling it any other way makes sense. It's too time consuming, it's too confusing, and people lose links, so you don't want to do that. So then the last thing is, who's going to provide technical support? This has been a hot topic during COVID, and I can tell you that people don't have the resources or the experience. So is it your IT staff? Is it a super user in your clinic who's just familiarized themselves? Are they tasked with being the person that if the provider has a problem or the patient has a problem, that they're going to provide support for the getting the consult going? So I don't expect you to read this in any sort of way, right? So this right here is just an example of a workflow. So again, it just basically goes from patient is identified as appropriate and has the technology. The office staff confirms the appointment and schedules it. The patient technology is certified, which means we test or we empower the patient to be able to be someone who can join a consult and have the experience. There's day of appointment procedures, and then there's follow-up, right? So every stop point, yes, no, is where somebody is unable to complete that flow. And if they can't complete the flow, then it becomes, you're not a candidate for virtual care. Please come into the clinic, right? Not everyone is going to be able to do this. And you need to sort out that decision matrix of when it's going to work and when it's not going to work, and then how to readjust and serve the patient. So again, facilitating the patient experience is so important. I think that it's a change management, but it's also this opportunity to invest in the patient in a new or expanded way to deliver care. And that's our goal, right? Our goal is the right care at the right time in the right location. So again, we need to verify that the patient can do this. We need to empower them. Do they have internet connectivity, right? Do they have the appropriate hardware? Can they access the software? Do they even know how to? And then ideally, is there a place where I can test this, right? If you took time and you met with the patient prior to a consult, they're now a virtual patient. Once you're in and you're with our organization, you're in for more than one provider, you're in for this option, right? So again, this is opportunity to orient the patient to the software, to identify the appropriate home environment for a consult. You don't want to be in the living room with the kids jumping around and the dog bouncing off the furniture. You don't want to have somebody gaming or playing Netflix at the time that you're doing a consult. You don't want to sit outside or in a bright light because you'll just be shadowed completely, right? So you need to empower them to say, here's an appropriate location. This is what this will look like. You need to confirm how the patient will access the virtual care. What are the next step instructions? Okay, now we've got you comfortable. You know you can do it on the day of your consult. Do this. It's a key piece to success, because they're like, okay, now I know what's going to happen. The expectation is set. And then again, you just build that competence and that confidence. I think that once the patient is confident with the expectations and what they're doing and their capabilities, their experience with the provider is going to be much better, and it's going to be a better experience for the patient and the provider both. So again, there are self-test options, because what we had is, hey, we don't have the staff to be calling every patient and figure this out. So we went, okay, well, what could we do for people? Well, we could say, here's the technology we're using. And again, this is available on the DOH portal. So again, you can have access to this, but basically in this case, it says, here's the requirement. You need a device with these things. You need internet. You need the software, right? So here's how I download the software. Click here and download it. Here's how I can test my internet. It's a thing called fast.com. I can be wherever and I can test it, and I can know, do I have the ability to do a video consult, right? And then there's places where you can test. You can click on test and you can see how the toolbar works, that your microphone it can mute and unmute, whether or not you even have a microphone or camera. If you don't have those things, they won't show up in the toolbar. So we often put a space available down below for scheduling or support. So for me, for Northwest Telehealth, it's like, and if you have a problem, contact us and we'll assist you. But if you were a clinic and you were handing some kind of one sheet out prior to a consult, this might be back to the clinic scheduler that says, I couldn't do it. And then that person can say, well, let me refer you to so-and-so, or I can't do it and I need to schedule my appointment in person. So give somebody a reason or an out to go ahead and move forward with, am I capable of this, or am I not capable of doing this? Okay, and I love the dog's picture in a mirror. I thought that was like, you know, kind of looks my dog. So then the experience, right? So it's the day of the consult. And there are things that need to occur for it to be successful. And this needs to be part of your workflow. What are the processes, the procedures, and who does it? So for the patient, when's the arrival time? Same as in the clinic. Do I have to have a copay, and how do I do that? Same as in the clinic. Who do I call if I'm stuck in the waiting room, or if I have technical issues, or I need to cancel my appointment, right? Kind of same as in the clinic, right? Although the technical issue might be my car didn't start. or I missed the bus, right? However that happens to be. But then follow-up procedures. What happens next? How do I do the next one? What are the steps after this consult? For the provider, it's the same thing, right? He or she has to log into software or click on an icon, figure out where that is. In today's world, with Zoom specifically, you have to admit a patient from a waiting room. That's a standard now with the license. So on the back end, could you put the doctor's name in the waiting room? So for example, for Dr. Van de Kief, it could say you've entered Dr. Van de Kief's waiting room. He will be with you shortly. That's something you can actually type in and put on the screen so that when the patient joins, right, they know they're in the right place. That's key to the experience. So again, it's a little software feature, but that feature makes all the difference. And again, there's introduction, right? Mostly historically, follow-up care has been what direct-to-patient has been about. You already know your provider, but in today's world, I think that has flexed and we're not sure. So we want to make sure that we introduce ourselves, we establish you're in the right place, we're the right people, and then often the protocol is, and hey, I'm Tammy Arndt, I'm with Northwest Telehealth, and you show some kind of ID. What are the documentation requirements for the physician, right? How does he note in that medical record or during the exam that all the requirements are satisfied for billing? Without this, you guys, without billing and this workflow development, you're not going to have a successful telemedicine service. The other thing is follow-up care and how that works. I want people to keep in mind that, again, as you put things together, you need to make sure that it's sustainable in terms of return on investment. If your goal is, I'm not billing, I just want to, which is the service we're going to provide to prevent readmission, right, into the hospital, make sure you're following whatever that is so it makes sense and the service is sustainable within your organization. So again, I'm a big proponent of replicating your existing workflow. You already deliver care. The difference is the location, right? And what does that mean? So I just kind of put this together in terms of assessment, preparing, and experience. Who is that, right? So in the assessment part, you want to include compliance, risk, all those people at your organization. You want to include the billing people because they need to make sure that everything's in place that we can bill for this appropriately. And then we cannot forget IT. IT is going to be the ruler of all things technology in terms of setting up the licensing, how patients access it. They're there to make sure that you can do your job without any of that other stuff in the way. When you prepare, you have to involve the clinic staff. If you're going to ask the scheduler to do something different, right, then they need to know that. If the MA is going to meet with the patient before the provider joins, the MA needs to be involved in how that they can do that. Again, the patient needs to understand that what they have to do for preparing, are you asking them to click into a patient portal? Are you asking them to open an email that's secure and finding a link? These are the requirements you need to do, just like driving your car, going into the office and checking in with the front desk. Whatever that is, you need to kind of follow that same scenario. And then again, for the provider, what are their expectations for joining the consult? Am I going to do this from my office? How much time do I have? All of those things. And then for the experience, the same thing. The patient, the provider, and the clinic staff, everyone's involved in this experience. If the doctor's running late, who's calling the patient? They're sitting in a waiting room, or maybe you know there's a cancellation. How would you do that if the patient was coming to your clinic? You would do the same thing. It's just a virtual patient. So instead of going to the waiting room and saying, oh, Tammy, I'm so sorry, the doctor's running late, it's going to be another 15 minutes, you would call me on the phone, right? So again, how do I communicate with my patient? How do I do that? Continuity of service so the expectation is there. Those are all things we have to think about in terms of workflow. So the last one I did, and this is the slippery slope of all technology people, is what if there's poor or no technology? And again, this is where the rubber meets the road. Often in rural communities, maybe the internet is not that great. how can I do it, right? I can't just say, well, sorry, we live out in a rural area and we can't do that. Well, you can, but again, it's an investment in technology and workflow and time. So there's two kind of models that I kind of think of. If there's the patient has the technology and you work through that, but then there's we arrive with the technology. So is it a home health aide? Who's coming to the home already? Who can we empower who's already coming to the home, or someone within our team to go there, who can come with a device? And that device can have the software already loaded on it, the meeting room already established, and there could be a hotspot or cellular service on the device itself, right? So that they don't have to rely on a patient internet service or connectivity to get them establishing the actual link in the consult. So the other thing is that if you arrive with the technology, that person can be trained as a telepresenter. So you've not done anything in advance with the patient other than someone's coming to your home, and while they're going to get you connected to the palliative care team, imagine all the services and all the people you can bring in through that, again, local portal, which is the device. So lots of options with that, but again, it's coordinating, it's purchasing the technology, coordinating the services, and making sure that everyone understands their role. And then there's the assign the technology to the patient. That's you're our palliative care patient, here's your device, take it home. So could you do that? Yes. Could you have some kind of tablet or device with a wireless service, or wireless device with a cellular service? Yes, right? It could be all kind of integrated in that. Could there be a link that says palliative care that you click on at the appropriate time and you see your provider? Yes. Can it be facilitated by both the patient and the caregiver? Yes, with some training, right? You'd have to train them at the clinic or go to the home to begin with to say, here's how you use this, some kind of easy way. In association with that, there'd have to be who can support me if there's a problem. Am I calling the clinic? Is it an IT person? So again, that would have to be built into your workflow. And then again, access to the palliative care provider. Is it just to the provider and then the provider brings in other, or is it to the team? So there's a whole workflow associated with assigning technology. And from a technology IT perspective, it's a scary, slippery slope because you have to lock down that device for all other things, right? You just want to make sure that there isn't potential risk associated with a device that you have given to a patient. So having said that, I'm going to stop sharing, right? And what I wanted to do next was I wanted to kind of introduce a couple of people on our palliative care team just with regards to their experience, right, and how this goes. So two people I wanted to introduce. One is Greg Vandekeef. I'm sure many of you know Greg, but he is a palliative care physician at Providence St. Joseph Health. He's an associate medical director for the Institute for Human Caring, and he's the medical director for this palliative care initiative. So because he's associated with Providence and they have done a lot of, they have a giant team of people who have integrated telehealth and they're kind of pretty good at it. I thought we would ask Greg about just his experience overall, maybe just for virtual care and how that's gone, but also if there's any direct-to-patient work that he's done. Greg?
Thank you, Tammy. Well, actually, a lot of what I wanted to speak to, you've already addressed so well that I won't replicate what you said. But some basic things that I do think are really worth calling out. The first is doing somewhat of a environmental scan or needs analysis. That is, what do the people you serve need, and how would development of virtual means of interacting with patients serve those needs? You know, the really fundamental thing. And then Tammy didn't quite utilize this terminology, but I think she demonstrated it nicely, which is really following a solid change management plan. With the accelerated rate of change management in particular, you want to be really mindful about what are the different things we're looking at here. So we started by looking, what are the type of virtual encounters we might deliver? There's inpatient encounters. We don't actually do a lot of those. We did some with the COVID restrictions to try and cut down on the utilization of PPE, but really we want to have as much as possible in-person interactions with people who are in the inpatient setting. But what about people at home? That actually was a much richer environment, especially with our palliative care patients, many of whom really struggled to get into the clinic in the first place. We had around a 30% no-show rate. And when I say no-show, many of those were very late cancellations. People with advanced illness, it's not surprising that they would be sick on the day of their appointment, and the day before the day of the appointment, they call in to cancel. And so I'm lumping those late cancellations into the concept of no-show. When we transitioned in mid-March to 100% virtual encounters out of our palliative care clinic, our no-show rate dropped from around 30% to nearly zero. I won't say zero because I did at least personally have one no-show, and I'll confess to this group, I accidentally no-showed to visit myself when I got busy in the inpatient service. Patient showed up and the doctor didn't. That's really poor form. So having somebody who can keep you on task is helpful as well. We look at a lot of interprofessional collaboration. If you have somebody in a critical access hospital who doesn't have a specialized palliative care team, is there a benefit in having access to other members of a specialized palliative care team that they can then connect with? And then it wouldn't be direct patient facing, it would be supporting other clinicians, so interprofessional collaboration. One of my favorite and more common types of virtual encounters are family meetings. When I'm on our inpatient service, if I have a son in Alaska, a daughter in Kansas that I really want to engage, we actually use iPads on a stand. The reason we put them on a stand is that keeps the picture stationary. If you have somebody trying to hold it, you know, it's going to be moving. Also, you can position the iPad such that all the person in Kansas or Alaska is seeing is their loved one on the screen. And then the other direction, some of you heard me told the story, very important pulsed conversation discussion with a guy who'd come off a ventilator and didn't want to go back on. We got his two daughters, one in state, one out of state, on the Zoom call, and they were both sitting there with their infants on their laps. So the first portion of the encounter was him reconnecting with his daughters and granddaughters. It was such a tender moment, I almost felt like I needed to step out. But then we needed to move into the goals of care discussion and the pulse conversation, and being able to do it in this manner where they could really see him in the hospital, how he looked days after coming off a ventilator. You know, it really provided a depth and a resonance to the interaction that you don't get from a telephonic interaction alone. And then finally, through things like our Project Echo initiatives and our Department of Health PC Ride initiatives, there's a whole lot around what I would call tele-mentoring, tele-education that needs to be taken into account as well. And so really setting things up, the planning and preparation phase, I like to think of these things in phase. Planning and preparation phase, the deployment phase, and then the optimization phase. And like planning and preparations, what we're talking about now, how do you develop the right change management tools? How do you have the right individuals, project managers, program managers who have the experience and the training to really effectively implement change management? With deployment, we often use a model called Common Frame that uses a term hypercare. Often when you go into deployment, the centralized planning process makes assumptions about what people on the local side are going to do and run with. People on the local side aren't necessarily privy to those assumptions, and the baton does not get effectively passed, if you want to use a relay metaphor, and frequently it ends up lying on the track and the program doesn't have a successful rollout. And so that hypercare concept is you identify who are the end users, how prepared are the end users, who's going to support, educate, socialize things with the end users, how are we going to interact during the immediate point after deployment to make sure that that hypercare, that added up, you know, support on steroids is there so that that transition goes smoothly. And then as they move into the implementation, optimization phase, then the centralized planning process can step back a little bit. There's a whole lot more I could say, Tammy, but I don't want to take up more airtime than I'm allotted, so I'll pass the baton back to you, and I know you'll want to hear from Deb as well.
Yeah, thank you. So I did, so just so everyone knows, our experience, for example, with Zoom and direct-to-patient pilots goes back several years. So again, we were doing small pilots. It was just kind of, can we do this and how will it work? And what we realized from our perspective was that that empowerment or support of the patient was super important. And I think in telehealth before, it's always been clinic to clinic, hospital to hospital, and that support of the provider was primary, right? It wasn't necessarily about the patient, but because of what has happened with COVID, it's really spotlighted that need to address that change and that empowerment of, can the patient do this from home? And I will say that even for Providence St. Joseph Health, they already had a patient engagement center that worked with helping. It was a place where you could call as a patient if you had problems with, like, how do I get on the portal? How do I log into MyChart? Well, they had all sorts of tools developed for assisting patients on how to do that. And then it wasn't immediately after they launched their direct-to-patient for all providers having Zoom, for example, and integration to Epic. But then they also eventually realized we can't have, we have people being furloughed. We have this whole chaos going on with actual clinic staff. Who can we get who can be an expert to help the patients get on? It's right now, right? So they assigned that to that patient engagement group, which I think was really key in changing the culture of how we deliver care in the future. Because once you get people, look at us, we're all on video today and we're all seeing one another. This has forced a cultural change for everybody, not just in healthcare, but healthcare has got a little special niche within how this goes. But the fact that we're all on video and we've all figured out how to do it, I don't care if it's, a virtual lounge with our friends, or it's seeing our family, or it's a healthcare environment, the fact that we've kind of empowered ourselves to, guess what, it's showtime, I have to figure this out because these are my options. Again, adoption is driven by necessity, but it doesn't exclude or exchange or forgive all of the things that Greg was talking about, right? And in long term, if we think about it, it's like, oh, I remember that COVID thing and it was a disaster, and I tried telemedicine once and I want no part of it ever again. I think that we have this opportunity to address things overall, and to take a look at how can we best affect that change management and develop that workflow so that there's a continuity of care. And to me as a patient, if it's appropriate for me to be able to see my provider at home for whatever reason, I should be empowered to do that, and I should have the option to do that as well. So having said that, I just want to, because again, this is just based on experience that we've had, I'd like to introduce Michael Jacobson. So he's an analyst here at Northwest Telehealth. He's our operator for this today, making sure that all goes well. But one thing that Michael's had quite a bit of experience with is certifying patients for virtual care. So we had this program during our pilots where we went, refer your patients to us, we'll get them good to go, we'll let you know they're ready, and then they're good for the rest of whatever. So I get that the cost and ROI of that story in the world today doesn't necessarily make sense, but we learned a lot about patients and about the home when we did that. So I just thought Michael could kind of like talk a little bit about most common roadblocks and the things that he's experienced as he's empowered patients. Michael?
Mostly we have, when you first meet a patient, you have to try to do a blind assessment of where they are, just through conversation. How comfortable do they feel with technology? You can tell within 10 seconds if somebody is like, no way, I don't like this, but I'm going to do it because I have to. Or some people are very open to it. They say, yeah, I'm an online gamer. I do this all the time, no problem. So you have to, they fall in a spectrum, and you have to try to talk to that spectrum, talk to that demographic, and try to figure out the best way forward. You're trying to empower them. You're trying to give them confidence, because a lot of people, especially, I don't want to generalize too much, but there's a certain demographics that are resistant to it. So you just learned some tricks. We just developed a check sheet that we just go down, and then you can kind of make notes, and then you pass these thoughts on to the provider later if it's appropriate as to what their problems are, low bandwidth, or they're technology resistant. But things like I can ask a gamer, I say, what's your bandwidth? And he'll tell me, oh yeah, I'm hitting 100 megs per second. And so, okay, that means something to me. But when I'm talking to somebody who's in the rural area and they don't know what I'm talking about, I'll say, do you watch Netflix? Okay. Do you get the little spinny wheel of death every time you start the show, or does it just pop right up? And they'll say, oh, one or the other. And then I'll say, okay, you probably have enough bandwidth. And we'll move on from there, and then we'll find out where they're at as far as their comfort level. Like I say, some people it's a 5-minute conversation. We're in and we're out. Other people's you take 30 minutes. Just one lady I had, she had to wait for her granddaughter to come home because she knew the password on the iPad to get her to download the software. So you kind of go with the flow, and you take them as they come. You try to help them understand that you don't do this at the Starbucks, that you're not going to do it like Tammy said with the dog bouncing off the wall. Try to keep a calm situation. And if the kids are in the other room watching Netflix, tell them to, cool it for a half an hour because it can suck down the bandwidth. There's just some little tricks that you'll learn. With a lot of people, we had a lot of no-shows, as Greg was talking about, no-shows just for the technology. Somebody had talked them into doing doing the virtual care, and really they were too hesitant. They didn't even want to talk to us about it. Others were hesitant, but once we talked them through it, and if you got the feeling that they were, on the borderline, I'd have them hang up and try it again. Try it 2 or 3 times. They would get comfortable, and then by the time we were done, they felt empowered that they would be able to do this. And then I guarantee you, when they got time, or when it came time to talk to the doctor, they were in, and you wouldn't have the missed appointments and the missed revenue from missed visits. Yeah.
Thank you, Michael. So, which is all valuable, right? So we've learned so much through the last several years, so much so that we developed that one sheet of here's the technology we use. And not only did we use it for patients, we use it for everything that's educational. Any registration that we do says, have you used this technology before? If the answer is no, we just pop out that with the registration so that people can go, oh, okay, here's how I do it. So I'm going to share the results of the polling. Can everyone tell me if you can see it? Right? So the polling is, have you implemented? So most of you have not, but some of you have. So that's good, right? That's probably based on some necessity. What's the success rate? So again, that 50% for those who have is about what I've heard overall based on the experiences we've had with people in the COVID era of, oh my gosh, it's technology, boom, figure it out. So this tells me there's room for improvement on how we do it, right? And then again, the majority of people today here have not implemented services, which is of course why you've come to talk about workflow. And then where does your biggest failure point reside, right? So for those that have implemented, you can see that there's patient and there's technology and there's other. Other could mean a variety of things, so I'm not quite sure what that is. But process is a big part of this, right? How do we even get started with it? So again, that workflow, I'll stop sharing this, right? So when I think about this, I think, again, we know how to deliver care. We do it every day. You are caregivers, right? So it's not about that. It's how do we do it virtually? So addressing the kind of questions that are the differences, look for the continuity between how we do this, and then just address those differences. It will make it less complicated. Bring in those people in your staff, in your organization that can answer the questions like, how do we do billing? Is this compliant? The IT people will provide support. Those are important. But also in terms of your providers, right? Their willingness to do it, their experience with this, their confidence that the care that they're giving is at the standard that they're wanting and that you're wanting as an organization. I think about Michael saying patient type. We've seen a whole variety of direct-to-patient services, palliative care, those delicate, compromised patients in the moment of their life. That adds a level of, I don't want to say complexity, but a level of paying attention to that empowerment and that ease, because their life is hard enough, and we want to extend this access to them. So it's like a no guts, no glory moment. It doesn't have to be perfect at the same time. COVID kind of taught us that, right? That it doesn't have to be perfect, but once we do that, now we have the opportunity to kind of develop something that makes more sense. I invite anybody to either unmute their microphone and ask a question, or ask a question in the chat. Specifically, where are you challenged most if you think about workflow? I'm going to ask Deb Watson, who is with our cohort in Pullman, and they've been working on workflow and delivery. And I believe Deb may have just recently seen a patient at the home. Deb, will you just unmute and kind of give your experience?
Yes. Good afternoon, everybody. We did see our first virtual patient yesterday in a session, and up front we had quite a few challenges, but we had people there ready to help us try to work through it, including helping the patient to work through. And overall, the session actually went quite well. We ended up with video via the Zoom on both sides, and phone call to the landline. We just weren't able to get the patient's audio to work on the cell phone that they were using, and we didn't want to tax them further by having them call in on the different numbers that we're seeing, in that Zoom link. And so we just decided to work with the landline, and it actually worked well. And in my testing with her in the previous week, I really was concerned that her bandwidth wouldn't support both audio and video anyway. So, but we had technical difficulties on our side as well, trying to set up the Zoom cart. And we'd come in early to try and make sure that it was all up and running. But people there to help too were a bit challenged, and we finally kind of managed to work through it. But I guess for me, especially on first sessions, recommendation to always be prepared for things to happen, and try to work through as much as possible prior to, and have help that you need there at the start to really get you off. I'm sure that as we learn going down the road and experience different things, that we'll be able to prevent a lot from happening, and then know how to troubleshoot some of the challenges along the way. We'll get better at that as we go along. But the actual session itself really went well on both sides. The patient and their spouse were pleased. We asked them at the end, to give some feedback on how this went for them. And I know initially the spouse was very hesitant, and she almost canceled with the testing and the connecting and downloading of the Zoom app and all of those pieces last week. It almost took her over the edge. But so it was nice to have it be successful, have them be happy that they didn't have to take the time to have him prepare, bathe, get dressed. I mean, he was dressed, but, special to come into an appointment. That saved both of them the time and effort, which is quite a bit on their end to try to prepare to come into an in-person visit. So for them, it was meaningful, and that they felt it went quite well. So I
am super proud of you. So again, think of the tenacity, right? To talk the patient into, no, we can help you get ready, right? That takes some effort, and that takes cheerleading. And then at the moment that you think you're going to do it, if it doesn't go well, right? Remain calm and telemedicine on, right? How can we, right? How can we say, okay, we've got this, right? So think about all the times you join a meeting and there's something that goes wrong, right? So to me, it's like, okay, you will develop experience, and that'll be super simple to go, it's usually these three things, right? But then again, just having the ability to, at the moment that you have the technology, to have some kind of support or some kind of person who can help resolve the issue. Once you do this, again, that fact that there was a survey afterwards that said something like, how did this go? Where was this at? A poll, right? How does it go for your providers? What about the clinic staff? How did Deb feel at the end of the day, right? Because you think about resiliency or burnout or effort, right? And all of those things are added upon us at a time where we're already delicate enough because our lives have changed, right? So
Right.
I think that, so you say to yourself, well, look at the great thing that that technology has done, but with it comes the recognition that it does take effort. The good news is, I'm hoping that this is true, that at the end they found it valuable, right? And at the end they're willing to do it again. So imagine your palliative care patients and that investment in time and effort in the beginning, then all the rewards of that down the road, not only for their quality of life, they don't have to get up and go when it's such a struggle for them, but then also for that touch point with the patient and that continuity of care, having that option. Could you do everything that way? No, but it just having the augment of that option, I think really allows a new experience and a new opportunity. So good
Yes.
for you, Deb.
Thank you. I will mention one last thing too. You know, we weren't able, the other gal and I weren't able to debrief after the meeting. She had to run off really quick, and that happens for a lot of people. And it was kind of nice actually to give us, you know, a period of time to kind of reflect and think back on the session. And so we're gonna huddle again and debrief on it so that we can review on our end, you know, how did documentation go? How did billing go? Were there things in the session that we would like to change the structure, you know, of how we went about that virtual session to make improvements and whatnot. So
I think that's going to be key, and you're right, that just speaks to the point of continual process improvement. There's no way it's going to be perfect the first time, and you'll develop things as you go. If everyone can, didn't see in the chat, Greg brought up some great points, right? So they're developing the following tools, and I know that I'm going to refer you back to the Department of Health palliative care portal, because we are doing a repository of tools within there to kind of help people along. So he's saying workflow guides for providers, patients, and families, right? Technology guides for computers, tablets, and phones. Zoom guidance for providers, patients, and families. What do I do? How do I solve this, right? Scheduling protocols, guides for the clinical encounter itself for providers, patients, and families, and documentation, and then last, billing and coding. So again, I think that this will, if you address these different areas, maybe you don't have all the answers in the beginning, but it's a place to start looking. So when you're developing workflow, you need to, again, take a look at what are the services, what are the requirements, what do we need to address, and start filling in there. Once you get it figured out, it's kind of rinse and repeat when it's direct to patient care, right? Except that oftentimes, especially in this patient population, it will mean additional things like remote patient monitoring. So there'll be additional tools that will be brought into your workflow. It will help with the care as well. So I think that you have to start in a place of here's where we're beginning and here's where we can go, and then fine tune through, again, that process improvement, your workflow and how best to develop future programs. So with that, we have a couple of minutes left. Does anyone else have any other questions or comments? I'll see if I can practice the Pat pregnant pause.
Tammy, I wouldn't mind making two real quick comments. One of which is, another way that I'm looking at this is to get away from either or thinking. That is, I don't want to think about, am I going to either see the patient in person or do it virtually, but how do we integrate the two? How do I see a patient and instead of waiting 6 weeks to see them in a long follow-up, have weekly interactions or every other week interactions that are more brief and support them better? There are a lot of models out there that have found that that yields some of the highest patient satisfaction. and some of the best outcomes. And I heard a hospice medical director saying earlier in the week that they'd had a patient who'd had a bunch of virtual encounters, and when a nurse finally got out to see her again, she developed a pressure ulcer. And his reminder was, this isn't replacing in-person care. It's augmenting in-person care.
Very good point.
And then the second comment is you talked about resilience. I have found people energized by doing this work. It is a lot of work, but doing cool, innovative, new, sort of leading edge stuff in the service of our patients and families is also very gratifying. And I found some people who were really kind of not fully burned out, but starting to brown out, have found that some of this work has really energized them and enhanced their sense of wellness and resilience. And that shouldn't be taken for granted.
Very nicely said. So with that, we're at the top of the hour. I really want to thank everyone for taking time to join us today and take a look at this topic. Cassie, do you have the date for the next educational webinar? I don't have it in front of me, but
I think it is late August, and just give me, it's on our portal, pulling that up real quick. It is August 25th, a guided tour to palliative care training resources.
perfect.
And then followed by September 22nd with legal issues at the heart of serious illness.
So we hope to see everybody for our next session, and thanks so much for joining us. Please stay safe.